Greetings, esteemed viewers. I extend my utmost gratitude for your presence at this particular juncture of the day. Permit me to express my heartfelt appreciation as I extend facilitation to you from the beautiful land of Kenya in the enchanting continent of Africa. As we commence this remarkable presentation, I humbly entreat each and every one of you to kindly consider subscribing, liking, and sharing the channel, which goes by the name Nandi Empress. I want us to look at adherence to TB treatment. Yes, adherence to TB treatment. Adherence to TB treatment is essential in preventing the emergence of resistance and increasing the chance of cure. This guideline provides practical steps to be used by healthcare workers to provide patient education and counseling to patients on TB treatment. Counseling explores and assesses psychological and emotional issues that could be pre-existing, drug-induced, or emerging in the course of treatment due to social pressures. The approach needs to be patient-centered and geared towards helping patients find their own solutions to daily life problems that may actually impact negatively on adherence. Counseling and education will aim to achieve the following. One of them is inform and educate patients and their caregivers on TB. 2, increase patient understanding on TB disease and treatment to enhance adherence. 3, empower the patient to take responsibility for the treatment. And the 4th one is identify psychological issues arising from treatment of disease presence and provide psychological support. Yes, guys, we're gonna talk about the 5th one. The 5th one is create harmonized patient education for the enhanced holistic care. The 6th one, my friends, is to improve patient and healthcare worker relationship. This relies on the quality of the therapeutic relationship established between the educator and the clinical team, or the clinic team and the patient. Let's look at patient counseling and education before TB treatment. Yes, before TB treatment, TB patients must be provided with the counseling and education sessions before the initiation of treatment and subsequently provided during follow-up visits. The counseling will be provided by the healthcare workers at the TB treatment center. The presence of counseling and education will follow the following steps that we are going to look at. Number 1, create rapport and assure confidentiality. Number 2, use simple, appropriate language that the patient can understand. 3, listen to the feedback of the patient and address any question that the patient may ask. Clarify information. Explore barriers to the treatment adherence. Also, provide information on TB treatment and adherence. Provide information about treatment services, which include the duration of treatment, possible side effects, and the importance of DOT follow-up visits. Guys, we need to explain the roles and responsibilities of the patient, family, patient supporters, and the care workers. We're going to look at patient counseling and education during TB treatment. We are from looking before treatment, but now during treatment. The counseling and education sessions will aim to develop a TB treatment plan in line with a patient-centered approach. The plan will include a schedule of clinic visits for treatment follow-up and counseling. The frequency of the visits will be weekly during the intensive phase and bi-weekly in the continuation phase. However, the frequency of visits for counseling education may be increased during the phase of treatment if issues that would affect adherence are identified. My people, my colleagues, my friends, the following will be conducted during the follow-up counseling and education sessions. We should do adherence assessment and supportive education. Another one, psychosocial review and support. And then also side effect monitoring. This is actually done during treatment. What about counseling and education schedule for tuberculosis patients? Yes, baseline counseling is done in the first contact with the patient. Provide counseling sessions at the time of giving results. The content aims to establish rapport and assure confidentiality. Educate patients on TB treatment and prevention transmission, common drug side effects, and other things. Educate the importance of referral of contacts for TB screening. Clarify information and dispel myths. Explore barriers to the treatment adherence. Explain the roles and responsibilities of the patient's family, patient supporter, and healthcare workers. Yes, people, let's look at intensive phase counseling. Phase counseling is done at every visit, which is weekly. If major issues are identified, arrange for frequent adherence sessions. The content will include adherence assessment and support, supportive education, psychological review and support, and then also side effect monitoring of the drugs. Continuation phase and follow-up counseling is done every 2 weeks until the completion of treatment. The content will include adherence assessment, support, and education, side effect monitoring, emotional validation, and reassurance. Now, let's look at treatment response follow-up for the bacteriologically confirmed tuberculosis. All patients should be regularly monitored to assess their response to the therapy. Regular monitoring of patients also facilitates treatment completion and allows the identification and management of adverse drug reactions. All patients, their treatment supporters, and healthcare workers should be instructed to report the persistence or reappearance of symptoms of TB, including weight loss, symptoms of adverse drug reactions, or treatment interruption. Yes, response to treatment in pulmonary bacteriologically confirmed TB patients is monitored by sputum smear examination. Clinical visits for the patient should be booked weekly during the intensive phase and twice weekly during the continuation phase of any anti-TB therapy. Yes, people, for the second or third month of treatment, a sputum specimen is sent for microscopy. If it turns negative, transition to the continuation phase is done. If it remains positive at the second or third month, evaluate adherence and other causes of delayed conversions and continue RHZD for 1 month or more. Request all drug susceptible tests like gene expert, first line LPA and second line LPA. Do culture, first line DST and second line DST. If DST results are received by then, adjust treatment regimen based on DST results accordingly. During the 5th and the 6th month, remove the sputum for another microscopy. If it turns negative, continue treatment until the end of the month. If it turns positive, declare treatment failure and stop anti-TB treatment. My people, patients must be reviewed by the County TB Clinical Review Team. That is the PMDT team. Evaluate the adherence after causes of delayed sputum conversion and treatment failure. Request gene expert, first line LPA and second line LPA. Do culture, first line DST and second line DST. Review DST results and reinitiate treatment based on DST results and other clinical findings. My people, during the 6th sputum, remove sputum for microscopy. If it turns negative with one previous sputum negative, declare patient cured and enroll for the post-TB lung disease care follow-up clinic. Yes? I think we are together. I want us to look at causes of delayed sputum conversion. Yes? Smear status at the end of the intensive phase is a poor prediction of which new patients will relapse. However, detective of a positive smear remains important as a trigger for the patient assessment as well as for additional drug susceptible tests. The proportion of smear positive patients with sputum smear conversion at the end of intensive phase is also an indicator of TB program performance. Yes, I want us to look at patient factors that may lead to sputum not converting. 1. Extensive cavitations. 2. Poor adherence, underdosage, malabsorptions, HIV because of reduced immunity, chronic diarrhea, diabetes mellitus because of immunity, older age, that is about over 50 years. You also look at smokers, the male gender, that is a careless gender, delayed consultations. Let's look at bacillary factors. High pretreatment bacillary loads, smear 2+ or 3+. Resistance, first line treatment failure with positive culture. Dead or non-viable bacilli with negative culture, possibly even up to the 4th or 5th month of treatment due to the bactericidal action of rifampicin and isoniazid. Non-tuberculous mycobacteria will always make it positive. High pretreatment bacilli loads, that is smears 2+ to 3+. What about drug factors? Let's look at number 1. Poor quality of drugs, expired drugs, and then poor storage of drugs. Yes, my people, my colleagues, we also have healthcare worker and health system factors. One is delayed diagnosis, inadequate knowledge among the healthcare workers, unavailability of guidelines, and then also lab errors. Poor supervision of the intensive phase, and then also poor health-seeking behavior in the community. Guys, this is the end of our discussion today. Thank you for sticking with me to the end. Remember to subscribe to my channel, Nandi Empress. Like, share, and always leave a comment. Thank you so much.